Okay, so we've decided to include cranial nerves, largely because, I mean, this presentation for me gives a lot of anxiety, just because it brings back lots of awful memories of being on the wards and challenged by some of the senior consultants. And if I'm honest, I really didn't know it that well, and I think a lot of other people, some know it really well, and that's great, but a lot of other students find it, neurological examination, particularly very difficult, esoteric, and it's not something we practice very often. We always go up and listen to someone's chest. It's easy, you just place a stethoscope on someone's chest in various places, but this you actually have to know a bit of anatomy, and you know, it's more difficult. So we thought we'd include it because it's something you do see when you're on call, and you have to know these kind of things. And actually, if I'm honest, until I saw Ed give this presentation, a similar one a few weeks ago, I was pretty much in the dark as well, but I'm much better now. So I'm going to assume that you know the nerves themselves. That's sort of first and second year stuff, and it might be worth going back and looking at them. Does anyone know nice mnemonic? So here's one here. So on old Olympus towering tops, a fine vested German viewed some hops. That wasn't the one you were thinking of, was it? But it's a good one. It's functional. I'm just going to go through the minimum knowledge that you need to know to be able to complete, you know, a cranial nerve assessment. And I see this a lot in notes and have written it myself, but probably shouldn't. You probably should explicitly examine people. And experienced clinicians can knock out a good cranial nerve exam if you're used to it in sort of 30 seconds to a minute. So it's not something that need take 10, 15 minutes. If you're used to it and you're experienced, you can go and do it very quickly. So it's something that you want to practice. Okay, let's go olfactory. Okay, that's the first cranial nerve. And what are some of the symptoms that you might get if you've got damage to your olfactory nerve? Loss of smell, yeah, sad, you know, it's, say again? And you might get loss of taste as well. That's not loss of taste sensation, but people may complain that their food doesn't taste as it used to. And again, you can do that thing where you get 5 or 6 Skittles and hold your nose and throw them in your mouth and chew, and then release your nose. Have you ever done that? No. It's brilliant. I do it on the tube all the time. It's great. So loss of smell. Anosmia, or hyposmia. No, I don't like that term. I just say anosmia. It's better. And it can either be temporary, caused by an upper respiratory tract infection, or it can be more permanent, such as nasopharyngeal tumours like a frontal meningioma, or trauma to the ethmoid bone in, say, an accident or you know, rugby player or something. And the reason it happens is because the first cranial nerve is sitting here through the ethmoid, the cribriform plate here, just above the ethmoid bone. So if you get infection and trauma to that area, you can get damage to the first cranial nerve and lose your sense of smell. And the way we test it in hospital is by testing with specific smells, and most of the things you'll see in outpatient clinic are out of date. But the hospital, I mean, you have to use your initiative, because the hospital's full of interesting and exciting smells. So you just have to use your initiative and try and find one that you can test people's sense of smell individually with their nostrils. So pick something sweet, and then pick something that maybe not so sweet. I'm sure you can think of a few things in the hospital. Cranial nerve 2 is the optic. And you should be really familiar with this diagram. I mean, in exams, I've always just drawn this out. I've just learned how to draw it, and it really helps me try and work out where a cranial nerve lesion is. And there's some highlighted regions here, but we'll go through each of the places and try and work out what kind of deficit we're going to get. So it's really important to remember that you've got a nasal and a temporal field. Okay, so that's the field of vision you see. So my temporal vision is out here, and my nasal vision is out here. But say I see something, so Ed sat over there. The light from Ed, the shining light that comes from Ed, is coming in, but it's hitting my nasal retina, because it's coming in that way. So it's my nasal retina that gives me my temporal field. I used to find that really confusing, but once you've got round it, fine. So let's go for the first one. So what kind of deficit are we going to get if, see the one at the top, we'll go from the top down. I'll just point my laser pointer. Is it working? Oh no. My favourite one. Okay, here. So what would you get with this kind of defect? Monocular blindness. Okay, yeah, good. And what sorts of causes? I mean, fear not, guys. And you can spend a Friday night in without fear. That kind of thing doesn't cause monocular blindness, but there are some causes of monocular blindness that you should know. Does anyone name any? Yeah, temporal arteritis. But with any cranial nerve, with any nerve, there are a number of causes that you should probably know that can cause damage to any nerve, like diabetes, syphilis can cause a lot of cranial nerve problems, arteritis can cause problems. You should know a few of them, and there are a few that you can use. Okay, how about, let's go over to these lists here. So we've got monocular, so demyelination, nerve compression, and occlusion of the retinal artery. There's some that are listed here. Bitemporal hemianopia. Where, if we think about that, so it's bitemporal hemianopia, so I can't see Ed and I can't see the fire exit, I can just see you guys, which is fine. So it's going to be the two nasal sides of my retina that are going to be affected. And if we go back to our diagram and look at it more closely, the nasal sides of the retina here are converging on this area here, which is the optic chiasm. So if you think about what lesions are going to give you a bitemporal hemianopia, they're at the optic chiasm, and it's going to be pituitary adenoma classically. That's a classic one in exams that you're going to want to look out for. How about homonymous hemianopia? So homonymous meaning on the same side. So it'll be the nasal field of one side and the temporal field of the other. So say I've got a left homonymous hemianopia, it'll be my left temporal field and my right nasal field. And that corresponds with the left nasal retina and the right temporal retina, because the light's coming in from the opposite side. So that's going to be caused classically by stroke or tumours. But if we go back to our diagram and see if that makes sense. So what happens is there's crossover. So the nasal retina of both eyes converges on the optic chiasm as we've seen before. But the temporal retina stays on the same side. So that if you get a lesion at the back here, so beyond the optic chiasm, then you're going to get homonymous hemianopia, because you've got the nasal field from one side and the temporal field from the other. Make sense? And you can work out which one it is, left or right. So it's always really useful to have this diagram in front of you, be able to draw it, because you can just work things out. It's how I do it most of the time. Homonymous with sparing, you might get posterior stroke, and also when you start getting things back here, it splits into parietal and temporal lobes, and you can get what's called quadrantinopias. So if it's the temporal lobe, you'll get a superior quadrantinopia. If it's the parietal, you'll get the inferior gone. Okay? Hope that's fairly straightforward. But if in doubt, draw the diagram. Then we look at these nerves together as a group. So the third, the oculomotor, we're going to look at the trochlear and the abducens nerve. And they all govern eye movements. So we'll assess them together. This is really useful to remember. This is the light reflex pathway. So when we write, when we see a patient, we write pupils equal responsive to light and accommodation. Ever heard of that, Perla? You see that written in the notes lots of times. Some people write it without examining, shouldn't do. So you should actually probably examine them and make sure that's true. But what does that actually mean? So the pupils look equal. They respond to light, which means they constrict to light, and via this reflex. And when you accommodate on something, so you tell someone to look at the distance, put a finger in their face and say, look at my finger, and you look at it, and then they accommodate, and both pupils should contract. It's via this kind of reflex. So what happens is, I always get these mixed up, afferent and efferent, but the way I've sort of learned to remember it is that afferent could be arriving, and efferent could be exit. So arriving to the nucleus where the reflex is initiated. So if I shine a light in my eye, I'm not going to because I've only got laser pens, that would be dangerous. Especially the green one. So if you shine a light in someone's eye, what happens is you're testing two things. You're testing the optic nerve, because that's the nerve that carries the impulse to the brain, and you're also testing the oculomotor nerve, the third nerve, and that causes constriction of the pupil. Okay, so when you shine a light in my eye, what's happening is my optic nerve is sending it into the brain, and it goes all the way to the back to the pretectile nucleus, somewhere in the dorsal midbrain, and then it sends it via the oculomotor. It goes through the, I can't even say it, what was it called, the Endinger-Westphal nucleus. It goes through the oculomotor, the parasympathetics of the motor nerve, and then that causes constriction of my pupil. And it will also happen on the opposite side. So if you shine a light in my right eye, my left eye will constrict as well via the same reflex. And in a sort of sympathy, it feels sorry for it, so it does it. Does that make sense? So can you distinguish between what you're testing for? So if I shine a light on my right eye and it doesn't constrict, and my left eye does, what does that tell you? Which oculomotor nerve? Which pathway? So if I shine a light on my right and it doesn't react? Yeah, so the efferent on the right side, isn't it? So the exit on the right-hand side. But you know that I'm not blind, you know that my optic nerve is working because the one on my left actually constricted. And you know that the oculomotor efferent pathway on the left-hand side is intact. Make sense? So that's how you can distinguish the two. It's quite useful. Because also, if you go and shine a light in someone's eyes and they're blind, you're not going to get any constriction. So it's useful to do that. And why you should check both eyes. Pupillary dilatation, the myotonic pupil. Does anyone know eponymous syndrome that causes a myotonic pupil? Holmes-Adey syndrome. And that's a myotonic pupil in the early stages, but can constrict. And the way I remember that is it's not very fair to her, but does everyone know Katie Holmes? You know, the famous Scientologist, married Sinus Cruise, Dawson's Creek star? Yeah. When I picture her, I don't actually find her that attractive anymore because she is Holmes-Adey. I always imagine her with like one eye that's really massive. And that's how I remember it, because she's Katie Holmes and it's Holmes-Adey's pupil. I get mixed up with all the pupils, so I always find really silly ways to work things out. And that's how I remember Holmes-Adey's pupil. Katie Holmes with a big, nasty eye. The second one is a third nerve palsy. That can cause a myotonic pupil, for sure. And drugs, so antimuscarinics, and that could be directly placed into the eye if someone's having cyclopedics for someone to look into the eye, they've just been to the opticians or something, that can cause it, and that's iatrogenic and purposeful. But also, if someone's had a cardiac arrest, and if they had asystole, what sometimes we do is we give them atropine, and atropine's an antimuscarinic, and that can cause pupillary dilatation. So sometimes you get confused and you think someone might be dead because their pupils aren't reacting, but it's not. It's because after the arrest they got given lots of atropine. So that can confuse things. Okay. Let's move on. Pupillary constriction, Argyll-Robinson pupil. Has anyone got a way to remember that? There are a number of ways. So I remember that. Does anyone know what it's caused by? Syphilis, okay. And it's often conveniently called prostitute's pupil. Have you heard of that? And it's great because of two reasons. One is that syphilis is obviously caught by some prostitutes, not all, but some. And also, does anyone know this? Yeah, the prostitutes, it accommodates but doesn't react, much like the prostitutes. So that's what the people do. It accommodates but doesn't react. And the way I remember this one is I remember a guy in a suit with a top hat from maybe Dickens' time called Mr. Argyll-Robinson who likes to sleep with prostitutes, and that's how I remember his Argyll-Robinson pupil. It's just a silly thing. If you can remember it without that, great. And Horner syndrome. So what's Horner syndrome? Say again? Yeah, so you can get invasion of the sympathetic ganglia by tumours and things, like a Pancoast tumour, and a Horner syndrome produces very characteristic clinical signs. Does anyone know them? Yeah, you've all got it, yeah. This. Yeah, ptosis, miosis, enophthalmosis is an apparent enophthalmosis because the ptosis is partly top and partly bottom, so it looks like the eye's gone back. And ipsilateral, so on the same side, anhidrosis, so sweat on that side of the face. I don't know how you would test that. Put them in I don't know how you would test that. Hey?
Do an MRI.
yeah. And some drugs can cause pupillary constriction. So you've heard of pinpoint pontine pupils, haven't you? And some people who take opioids can have pinpoint pontine pupils. So that's an important cause there. So this is the Horner syndrome. Ptosis, miosis, anhidrosis, and apparent enophthalmosis. Cool. The oculomotor, the trochlear, and the abductions govern all the eye movements. And basically, the oculomotor does everything apart from two. Does anyone know which one governs which? I mean, you can see it up there. So the lateral rectus. Yeah. So I remember the chemical formula LR6SO4. Does anyone remember that? Lawrencium sulfate. I don't think that compound actually exists, but it's the way I remember it. So LR is the lateral rectus is innervated by the sixth nerve, and the superior oblique is innervated by the trochlear, the fourth nerve. So LR6SO4. And oculomotor is pretty special. It does everything else. So not lazy like the other two. Isolated lesions are quite uncommon, but can occur with trauma to the orbit. So like rugby player getting knocked or someone in a fight getting punched, that can cause isolated lesions, but they are quite rare. I wanted to show you a couple of YouTube videos that may or may not work. If they don't, I'm going to have to switch to the PC because we don't have any internet otherwise. I'm going to swap PC and show you this lovely girl with this. There she is. Can you see that? Let me pause it there, actually. Let's go back and just see that again. So what's wrong there? She's being asked to look to her left. Yeah, so she's got a left sixth nerve palsy, so she's paralysed her lateral rectus muscle. Cool. And these are some helpful YouTube comments attached to the video. So someone said, "Who is this girl? I'd like to get to know this person." Which I think is brilliant. And Mini Squint had posted, this is 8 months ago, "Nerve palsies like sixth nerve should not be recurrent, nor do you grow out of them. I would get an MRI for your daughter right away. This could be serious. 1/4 of sixth nerve palsies are caused by brain tumours." It's a bit insensitive, isn't it, to post on a YouTube video? But I mean, it's probably sound advice, and I'm sure that's why she was in the clinic. So causes, as Mini Squint had alluded to, tumours, multiple sclerosis, and infarction can cause those. Okay, oculomotor nerve palsies are by far and away the most common, though. And the oculomotor, as we said, supplies all except the lateral rectus and the superior oblique. It also supplies a number of other things, like the sphincter pupillae, so you get pupillary dilatation, and the levator palpi superioris, which governs our eyelid. That I've had really bad spasms with the last week. Maybe it's because I was on nights or drinking too much coffee or something. I'm not sure. So let's show you another video. It probably won't work, so we'll go over to here. Oh, no. Let's get rid of her. Lovely as she is. Have a look at this one. So which is the problem eye? Here's right, yeah. So not moving at all, is it? And it assumes the down and out position. There it is, down and out. Not moving. Moving a little bit, but not very much. It's pretty horrible, isn't it? Unfortunate individual. Okay. And there are two types. So there's what's termed medical and what's termed surgical. Has anyone heard of this? And what's the difference between the two? Oh, it's there. So medical, you get pupillary sparing, and that's because the nerve is damaged, the oculomotor nerve is damaged itself, whereas surgical, you get the pupil involved, and it's because of this reason. So medical, as we've said, you get this nerve on the outside damaged, and the parasympathetics, and they're what govern pupillary. Remember, we saw the reflex before, that constriction is a parasympathetic phenomenon, and this is carried by, in the middle of the nerve, in this sort of pupil bit is where the parasympathetics lie, and if you get compression, you also destroy the parasympathetic innervation, therefore you get pupillary dilatation. So in medical, oculomotor nerve palsy, you won't necessarily get pupillary dilatation, but in surgical, where you've got compression, usually by, say, a posterior communicating artery aneurysm or tumour or something like that, then you're going to get early pupillary dilatation. That's it. So trigeminal. What does trigeminal do? There are two branches. There's a motor. Well, there's actually more branches, but there are two components to it. There's a motor component that covers all the muscles of mastication, not with a B, and it also has a sensory portion, and we divide that into V1, 2, and 3, don't we? So there's the ophthalmic distribution, there's the maxillary and the mandibular. Yeah. And isolated lesions of the fifth cranial nerve are quite rare, but do happen transiently, say in herpes zoster, or can happen with cluster headaches. You can get transient trigeminal nerve palsies, so it's important to ask about those if someone does have cluster headaches. And you usually get them in association with, you get 4, 7, and 6, all you get them tied up as a bundle when you've got CPA tumours, so cerebellopontine angle tumours like acoustic neuromas can cause problems with all of these nerves. So here's the facial nerve. Facial nerve does a couple of things. It governs all the muscles of the face apart from the ones innervated by the trigeminal, the ones we use for chewing and chewing, not swallowing. And it also provides, what, does anyone know the other thing? Taste to where? Yeah, brilliant. You know this already. Why are we doing it? So it conveys taste to the anterior 1/3 of the tongue via the chorda tympani branch, which runs along with the trigeminal. So sometimes if you see someone with an isolated trigeminal nerve palsy, plus they've lost the taste to the anterior 1/3 of their tongue, you know that somewhere along that branch they've been damaged by something. It could be dental infection, whatever. Okay, another YouTube video. This is bad. I really wanted this to have sound. Does it?
Okay, here's Dad and his.
Just regular talking is really kind of difficult. It's also on one side of my mouth.
Try to blink your left eye.
Try and lift your eyebrows. It's getting better though. This is after doctor's appointment.
What's weird is my left eye takes a while to focus too. It's really sluggish. So, my depth of vision thing is really good.
He's fun. So here's blinking. Yeah, I like that guy. I don't know why his daughter found it so funny, but I thought it was funny. So facial nerve palsy we can divide into upper and lower motor neurone. Upper motor neuron has a sort of dual innervation from either side. There's some crossover. So you usually get frontal sparing, and you get the orbicularis muscle spared as well. And causes of an upper motor neuron lesion there are stroke. Lower motor neuron lesion, as we just saw there, like a Bell's palsy, you don't get frontal sparing. So that guy didn't have any frontal sparing at all. And so HSV can cause Bell's palsy, but also some tumours can cause it as well. Nasopharyngeal tumours, particularly parotid, can cause that. What's this? Go on, someone said it. Yeah, so that's Ramsay-Hunt syndrome, heard? So that's a zoster infection within the ear that can cause damage to the facial, because the facial nerve goes comes out through the ear as well. So that's why if you've got a CPA tumour, like an acoustic neuroma, you get the facial involved, because that's where it comes out. Then it comes with the trigeminal as well. And 8, the vestibulocochlear nerve. So as its name suggests, it's got two parts. There's the cochlear part and the vestibular part, and The cochlear part deals with hearing, and there are different types of hearing loss, conductive and sensory neural. Does anyone know a way to test? Which one? There are two tests, and there's Rene's test and Weber's test. Who thinks it's Weber's? Hands up. Very good. So it's Rene's test, and it's one where you get the tuning fork, place it on, you say, can you hear that in the air? And air should be greater than conduction when placed on the mastoid process. And what's Weber's test then? Yeah, it's when you stick it there and see if they can hear it louder in either ear. So conductive losses, causes could be wax, perforation of the eardrum, otitis media or otosclerosis, many different causes. Sensory neural loss could just be loud music, old age, could be acoustic neuromas, infections such as mumps and meningitis, Meniere's disease, what's that? Yeah, it sounds like you'll know it by the general mumble. So you get attacks of vomiting, room spinning, and hearing loss, don't you? And eventually it leads to sort of sensory neural hearing loss. And some drugs, like the aminoglycosides, such as gentamicin, can cause damage to that nerve and therefore cannot hear. Then we're going to go on to these nerves. So the bulbar nerves, the glossopharyngeal vagus accessory, cranial root of the accessory nerve, and the hypoglossal. And these are termed the bulbar nerves. And they all originate from the medulla, and isolated lesions of them are rare, and they're usually grouped together. And there are sort of two concepts here. Anyone presenting with dysarthria and dysphagia, you should really be doing a cranial nerve examination to check all this out. And there's an upper motor neuron lesion and a lower motor neuron lesion involving these groups of nerves. And a pseudobulbar palsy, you're going to get a small spastic tongue with no fasciculations, and they're usually associated with emotional lability. And the way you differentiate this from a lower motor neuron is that the jaw jerk is exaggerated, whereas a lower motor neuron is not. So let's see that. So lower motor neuron, you get wasting of the tongue, usually get fasciculation, so you get sort of a saggy, flabby tongue that fasciculates around, and the jaw jerk will be normal. Okay, so that's it. Quick run through of cranial nerves. And hopefully now you'll no longer write neurology grossly intact. You might do when you're busy, but hopefully you won't. And I hope this has been useful for you for when you come up to your sort of clinical exams and everything. Thanks.